A very good morning to everybody. Thank you, organizers. Thank you, the chairpersons. Thank you, everybody who has come in early in the morning on a Sunday. I won't be boring you a lot much. And as Sir said that yes, we are presenting our data, but at the end of the day, the surgeons are those who cure the patients, and we tend to approach towards the curability by our weapons which we have. And that's where I would request. Let my slides be shown. So my topic is the new or adjuvant systemic therapies in patients with early HER2 positive breast cancers. And I won't be going much back, but we all have established that yes, in HER2 positive, giving HER2 directed therapies have always shown advantage. This is the meta-analysis where you could see that 1 year adjuvant trastuzumab improves the DFS compared to giving no trastuzumab. The HERA trial, the B31, the BCRG group all showed that the advantage ranges up to 30% to 40% reduced chances of events. And there is an improvement in overall survival also. And we have been trying our level best to de-escalate attempts by shortening the duration of adjuvant trastuzumab. And we have 3 trials for the same with around 12,000 patients where we have gone up to as low as 9 weeks in short HER and SOL study and up to 6 months in FAIR, HOG and Persephone study with non-inferiority results. At 11 years follow-up, why do we need more treatment for these patients? As you could see, those who are cured by chemo are 62.5%. The magnitude of benefit is 11%. And then again, you could see there is those upper graph where we think they need more and more treatment to make them approach towards the curability. And that's why adjuvant trastuzumab plus the chemotherapy, we tried obviating the chemotherapy from these arms, and you could see the results couldn't match. So there was a trial where prospective small node positive or node negative tumors, HER2 early breast cancers, and if you look at the T size was less than 3 centimeters. The 2 regimens that were given was weekly paclitaxel followed by trastuzumab, AC followed by weekly paclitaxel, and you could look at the DFS of these 2 arms. So if you look at the meta-analysis of the 5 non-inferiority randomized controlled trials, the IDFS rates were 89 versus 88.56% with an adjusted hazard ratio of 1 showing non-inferiority. And that's where the combination of what more can be done to those groups who don't achieve the responses or don't have the exact cure of the disease. You add pertuzumab to those, and you could see the node positive patients at 74.1 months for a median follow-up. The hazard ratio again was 0.72, meaning 28% reduced chances of events when you add pertuzumab instead of not giving. When you look at those who were node negative, again, you could see the curves were exactly matching each other. So hazard ratio exactly 1, meaning not much benefit there. When we look at the 8.4 years of, again, trastuzumab plus pertuzumab combination, the node positive disease is something where you see that, yes, the graphs tends to separate, and they tends to separate consistently with the hazard ratio going up to 0.8, meaning a 20% reduced chances of it. EXTET study where HER2 positive breast cancers were again given post 1 year trastuzumab, neratinib, 1 year, 240 milligram per day dose. And you could look at the benefit was on hormone positive population only. So a delta of around 2% was seen across year by year follow-up of them in IDFS rate, and there was a correlation between the PCRs and the outcomes. So the higher you achieve in the PCRs, it is a surrogate marker for EFS and overall survival, and therefore it is a surrogate marker at the patient level that you can prognosticate for the same. And which drugs increases the PCR rates? These are through various combinations. You have seen that instead of giving only trastuzumab, you have to add something more: trastuzumab plus pertuzumab, trastuzumab plus lapatinib, the trastuzumab plus pertuzumab. In the Trepinas trial, you could look at the pathological complete response rate. Be it ER negative population, also the benefit was seen. And post neoadjuvant trastuzumab, if you have not achieved a pathological complete response, there is something you need to escalate. That's shown by the Catherine study. Again, you could look at the hazard ratio of 0.5, meaning a 50% reduced chances of events if you give in adjuvant TDM1 instead of giving trastuzumab. For these patients also had an overall survival 30% reduced chances of deaths when you give TDM1 as an adjuvant treatment in those who haven't achieved a pathological complete response rates. The delta figure is 6.7% of the DDFS with a hazard ratio of 0.6. So post neoadjuvant, the Catherine study trial did show that yes, there is a need to escalate, and that's where the IDFS and also the OS benefit was seen all across the subgroups be taken across. Now comes the role of the immunotherapy, the Impassion 50 study, where HER2 positive heavy node disease N1, N3, T2 to 4, when given with chemotherapy, atezolizumab in the neoadjuvant situation, and the primary endpoint was the pathological complete response in the intent to treat and the PD-L1 positive. If you look at the complete response, they did not increase with the addition of the immunotherapy in either the intent to treat population or the PD-L1 positive population, with the delta figures nearly same. So also, if you look at the event-free survivals, the combination of the immunotherapy plus the chemo, 96.3% versus 97.9%. So again, the data hasn't been matured to add immunotherapy right now to those patients, even if they are PD-L1 positive in HER2 positive patients. The Fergain study again looked at the stage 2, 3B HER2 positive breast cancers, and they randomized into the pertuzumab, trastuzumab plus the chemotherapy combinations versus the endocrine therapy combinations. And this was looked at the de-escalation. And you could look at, again, those who responded to PET were having a surrogate marker of a pathological complete response. So again, this study is something which needs survival outcome data. But yes, PET CTs can be used as a surrogate markers for the same. The adjuvant HER2 positive trial, where TDM1 versus paclitaxel plus trastuzumab for weekly, followed by 3 weekly. In a stage 1 HER2 positive, ER positive or ER negative, we look at TDM1 more distinct continuations due to the adverse event 17% versus 6%. The DFS was there, the p-values were significant. So the question comes, do all patients need anthracyclines? And when we look at the TCH regimen, it shows similar DFS, OS, the long-term survival data, at least 10 years of follow-up for these have shown that the overall survival is maintained with the anthracyclines, taxanes, trastuzumab combination. It is 85.9, and with the TCH regimen, the 10 years overall survival is 83.3%. So similar DFS, similar OS. The TCH has great lesser grade 3, 4 arthralgias, myalgias, hand-foot syndromes, lesser leukemias, and lesser cardiotoxicity definitely for it. So look at the cardiac events, definitely much reduced with the TCH as compared to giving anthracyclines. Anthracycline-based chemotherapies, more febrile neutropenias, more cardiac toxicities, more ejection fraction declines, more secondary malignancies, including leukemias, slight less neuropathies. So definitely, if you look at the event-free survival, again, the graphs exactly superimpose over each other with hazard ratio crossing 1. So these are the trials where we are looking in future when the trastuzumab deruxtecan, the blockbuster molecule, is being added in the neoadjuvant and the adjuvant situations with a target PCR of achieving around 56%, incremental benefit of 15%. So we will be targeting around 70% PCRs for it. The Destiny Breast 5 study, again, trastuzumab deruxtecan vis-a-vis trastuzumab TDM1 in the adjuvant situation is there. For now, early breast cancers, HER2 positive chemotherapy plus anti-HER2 therapy is the gold standard for across all indications. Even it's ER positive, HER2 positive, the chemotherapy plus endocrine therapy plus anti-HER2 therapy is there. And post-operate, if you don't achieve pathological complete response, there is TDM1. If you achieve pathological complete response, it depends upon whether you have used in the pre-operative chemotherapy trastuzumab plus pertuzumab. On node positive patients, you have to give 1 year of dual blockade. In node negative patients, you can get away with the pertuzumab. You can give only 1 year of trastuzumab. These are some of the guidelines which I have taken references for. And this is how we usually manage our patients for a less than 1 centimeter lesion with node negative surgery is contemplated. For 1 to 2 centimeter lesions, TCH is usually given, and then we look at the pathological complete response and decide our management based on it. For more than 2 centimeters on a node positive disease, anthracyclines are definitely given as an option to, depending upon the whole comorbidities and the fitness profile. If the pathological complete response, trastuzumab plus pertuzumab. If no pathological complete response, TDM1. Thank you. Greetings from Kanpur. Love to answer any questions if there are any.
I've learned a lot. Dr. Somshekhar will vouch that this is a phase which has never come before. Previously, it was just surgery, 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 surgery. This is the first time where the medical oncologist has told surgeons, please stop. And we have seen the phase where everything was just surgery. Any breast comer was given surgery. Then came the concept of early and advanced and giving chemotherapy. And then we have seen the advent of Herceptin. And today, even in early breast cancer, you are saying, stop, Sanjeev, don't operate, give the case. So this is a very exciting phase. And I would invite questions from the audience.
You said the anthracycline based versus TCH, the DFS and OS is same. What about PCR rates? Are they same?
So it depends upon the node positivity. So the addition of the anthracyclines, the beneficial subgroup where it had a complete response more as a surrogate marker, and the DFS was separating was in the node positive population. So when there is a node positive population, there is a benefit of adding anthracyclines, but for the rest of all others, we can obviate with the anthracyclines. With the 10-year good follow-up, the OS is same, the EDFS is same, the
OS and DFS is same. I'm asking of PCR. Does the PCR remain same?
So whenever we deal with the PCR rates, it also depends upon the arm, whether we use the trastuzumab combination, we use the trastuzumab pertuzumab combination, and that's where that study had a lacuna, because now the trastuzumab pertuzumab combination is recommended in the neoadjuvant city in the node positive population for increased pathological complete response. So definitely, if you are using the TCH group, we have to add the pertuzumab in the neoadjuvant situations to increase the pathological complete response rates if we want to avoid the anthracyclines for the same. So with every addition of the dual anti-HER2 agent, so with trastuzumab plus pertuzumab, you can reach, as I showed in the graphs, it depends upon whether it's a hormone positive or it's a hormone negative. And the incremental benefit is more in a hormone negative population, where you see from around 50%, there was a 60 to 62% of pathological complete response rate with the addition of pertuzumab and trastuzumab in it. And if you don't achieve the pathological complete response, you have to change your adjuvant situations depending upon if you have used trastuzumab plus pertuzumab, you have to use TDM1 in the adjuvant situations.
And the pathological complete response is really pathological, or it's on the basis of radiology that have gone as
Pathological.
only
It's
pathological?
pathological. PET CTs are now being used as a surrogate markers, but they don't have an established outcomes for now.
For a young female neoadjuvant setup, if you plan a TCHP and if she's not affordable for pertuzumab, so do you consider anthracyclines, addition of anthracyclines in that case? AC and TH instead of only TCH, young female, node negative.
So AC followed by weekly paclitaxel plus trastuzumab is something which is a good regimen that we have been using over the past. Using TCH plus anthracyclines, because you're giving already trastuzumab, you can't add anthracyclines at the same time.
Whoever is you have planned for TCHP, dual anti-HER2 blockade, but they are not affordable for pertuzumab. For them, do you consider only TCH or addition of anthracyclines, AC and TH?
With TCH, you can't add anthracyclines because
No, that's fine. I'm saying sequential, AC followed by TH instead of TCH regimen.
Give 4 cycles or 6 cycles TCH, look at the response, and then decide your adjuvant based on the pathological complete response or not. So if it's not pathological complete